Thank you very much, Maureen. Thank you for inviting me to speak on non-narcotic pain management alternatives for hernia surgery. I'd like to begin with... Do we have a... So I'd like to talk about the perioperative pain management strategies that can be employed, including preoperative considerations, intraoperative choices. We'd like to discuss chronic persistent pain post-herniorrhaphy, which is a well-known condition, and what non-narcotic options there may be to help manage these conditions. And the stress on the non-narcotic options is that there is growing concern with the prescription drug abuse epidemic in the country. And given that, trying to minimize its use and optimize it makes sense, but also because the side effects from the opioids, including slow bowel recovery and nausea and vomiting, can sometimes be a concern as well. So in the preoperative considerations, we had a great talk on optimizing management for anxiety prior, because many times we are using pain medications to address mood and anxiety, and it would be more optimal to treat the condition with other things. And then I'd like to talk about the concept of preemptive analgesia and preventive analgesia, and what is the difference there. So preemptive analgesia, the emphasis on preventing central sensitization, which is supposed to lead to the chronicity or the persistent pain or a high degree of subacute pain after the surgery, is giving medications or using strategies prior to the incision to minimize these complications. As you can see in these graphs next to you, normally what will happen is the first one, A, where you see pain from the initial surgery and the hypersensitivity that subsequently develops all across. In B, you can see that traditionally what we do is administer analgesia after the surgery has occurred, and at that point sensitization has already occurred, and you may get some short-term benefits, but in the long term the hypersensitivity continues to be an issue. In C, where the analgesia was administered before surgery, it limits the pain from that stimulus and actually does impact subsequent hypersensitivity. However, the most effective preemptive analgesic regimen is initiated before surgery and continued throughout the postoperative period, which is what is called preventive analgesia. So the concept is this isn't just about doing something just before the incision and then not doing anything different afterwards, but to continue those therapies and those strategies throughout the perioperative period and into the postoperative period. So although the timing, which is what we've been talking about, is important of the intervention, it's also important what intervention is being used, because there are only some that actually prevent sensitization. And as you can see in these strategies, when you give narcotics, opioids, or alpha-2 agonists, they work at at the cerebrum and the dorsal horn, and you have local anesthetics and anti-inflammatory drugs that act more peripherally as well. An example where they've shown, there's a paper actually on hernia surgery that shows benefit is infiltrating the incision site with long-acting local anesthetic, bupivacaine, after administering general anesthesia, but before the incision. They found that there was effect that lasted well past that. Now, there is some controversy with regards to preemptive analgesia. When these strategies are employed in animal studies, we see immense relief and immense effects, but you don't get the same consistent results when you use them in humans. And the thought is the pain thresholds that we inflict on animals for the studies is different from the pain stimulus that humans experience during surgery. However, there is enough data that this may be of value, again, towards optimizing the pain management for these patients. So speaking now of preventive analgesia, again, to focus in, what we're trying here is to reduce postoperative pain and consumption of analgesics, and its most effective means of decreasing postoperative pain. And the way we would do that is to use multimodal preoperative and postoperative analgesic therapies, which will result in this phenomenon for you. So intraoperative considerations are also important, as you've heard in previous talks. This surgery can be done under local anesthesia. You could use general anesthesia. You can use regional techniques, including spinals and epidurals. Here I'm just discussing a paper where patients receiving local anesthesia reported significantly less pain and nausea postoperatively than the other groups. However, local anesthesia is not appropriate for all cases. The other thing they found were opiates were given to only 8% of patients receiving local anesthesia, where 22% of those receiving regional and 34% of patients receiving general anesthesia needed opiates in the postoperative period. And no patients in the local anesthesia group required, catheterization for urinary problems. 8% in the general anesthesia group and 29% in the regional anesthesia group required catheterization. And the duration of anesthesia and hospital stay was significantly shorter in patients who received local anesthesia, but operating times were found to be longer in this study. A more recent Spanish study on cost effectiveness showed general was more cost effective than spinal. Now here they only compared general anesthesia to spinal anesthesia. As far as the regional techniques are concerned, again, you could do local anesthetics, you could do epidurals, you could do spinals. There is also continuous ilioinguinal and iliohypogastric blocks, and this is different from just a single shot block. The thought here is that if we were to leave catheters in, you would get that postoperative period as well, and could continue. These are just picking up in favor right now, as are tap catheters. So you can do the tap blocks, and as you heard in a previous talk, if you use longer-acting liposomal bupivacaine, that actually, the effect actually lasts longer, and this can be achieved either by doing something like that, or you can have catheters placed. These are outpatient, by the way. Patients can go home and remove these catheters themselves. So outpatient catheter programs with both of these techniques are gaining some steam. You can perform the surgery under this. They can give you density, enough density that you can perform the surgery itself without having to go to spinal or epidural if you were opting for a regional technique for it. So persistent pain after hernia surgery, again, this is unfortunately a well-reported condition. Its exact cause why this persistent pain develops is not very clear. However, the theory is there's entrapment in one way or the other of the ilioinguinal, iliohypogastric, or the genital branch of the genitofemoral nerve, either in the sutures, the mesh, or the scar tissue. The incidence, anywhere from 9 to 16%, and in some papers as much as 28% of patients show this chronic persistent pain. It seems to be mostly following mesh repair, however, and less so with sutures or scar tissue being implicated. So how would we treat this? What would our recommendations be? Again, as I stressed in an earlier slide, multimodal analgesia, not to use just one agent and hope that the patient will do better, but try to use a combination of things to both preempt and prevent postoperative pain. Perioperative pain, can also result in hyperalgesia. So the concept is they're actually hypersensitized, and narcotics or opioid medications can definitely cause it as well, especially high-dose medications. Especially if your patient was already on opioid medications for any other condition, the chance that they will develop issues afterwards, or chronicity, is reasonably high. And if they have any other symptoms of central sensitization. So multimodal analgesia can help you improve pain management, it can decrease your opioid requirements, and possibly the opioid-related side effects we just discussed. So what do you use for it? Atypical analgesics, such as ketamine, pregabalin, gabapentin, IV lidocaine, and alpha-2 agonists. I will be discussing each of these in a little bit more detail in the next few slides, except the IV lidocaine, which for hernia surgery is not as applicable because it's really more helpful when you have a lot of visceral pain. So this graph that you see below are the transitions from acute to chronic pain, and the thought is that if you can get them early before, even the transient activation, but definitely before sustained activation or hyperalgesia sets in, is how you can prevent, and your outcomes can be much better. So ensuring that you're addressing this all through the continuum is how you can have the best results. So gabapentin or pregabalin, these were originally developed. They are anticonvulsants, class of medications, but actually do really, really well for neuropathic or nerve-related pain. And the evidence for that shows, you have level 1 evidence that there's improved analgesia with these medications at rest and with movement, improved functional recovery with better range of movement and pulmonary function. And the analgesic effect, how much pain relief do you get from this, is pretty comparable to what you would get if you gave them non-steroidals. And it's actually superior to tramadol, which is gaining a lot of favor recently just because many of us believe that it's not a strong narcotic. Useful adjuvant to epidural analgesia as well. There's decreased pain scores, analgesic consumption, and patient satisfaction, though there can be an increase in dizziness. So it's a useful preventive analgesic effect. So it's not just preemptive, i.e. there are some strategies where people will say give 1 dose of gabapentin or pregabalin before surgery, and you can reduce opioid consumption in the immediate postoperative period. You might be able to achieve some of that in some of those papers. However, the problem is that you're not going to see a reduction in your overall recovery and the incidence of chronic pain afterwards. That will only be achieved if you can continue this gabapentin for a short period afterwards. What we normally do is we do give them a dose of gabapentin before, or sometimes we start it 2 to 3 days before if we have that opportunity, especially in any patient who is opioid tolerant. And we continue it for 2 weeks afterwards, after which there is a trial off of the medication, and if the patient complains of any return in pain, we then continue it for 4 more weeks. And with that, we really have been able to significantly lower our chronic persistent pain issues after this surgery. So again, not just a preemptive, it's truly useful more as a preventive analgesia. Ketamine, it's a useful adjuvant as well if you can use it, especially in upper abdominal, thoracic, and major orthopedic surgeries. Hasn't been used as much for hernia surgery. It's a useful adjuvant to PCA analgesia as well. Again, this is more something we would recommend in patients with a lot of chronic pain already, whom you're operating on, or who have had, you're doing this surgery the second time for recurrences. You might want to consider something like this, but I wouldn't recommend it for like first pass surgeries. So it's, again, as I said, for chronic pain issues and those on high dose opiates. Or opioid resistant pain. It's great as a rescue analgesia. Again, a preventive medication, not truly preemptive, so you can't just give a dose of it or just continue it in the OR and then stop it in recovery. You would have to continue it afterwards. Now, ketamine is usually used intravenously in the hospital setting. You can prescribe it as an oral medication after surgery in these patients, but please also recognize that this drug is also a drug of abuse, and there is, hallucinogenic effects with this, and patients can have psychosis, etc. So it's not always the easiest and the best tolerated unless it's used in appropriate doses and with good patient selection. So studies looking at the role of ketamine, therefore, in chronic persistent pain have shown only mixed effects because of that. You can also use systemic alpha-2 agonists, so you can use agents such as clonidine or Dex, and these are moderate analgesics. They could cause hypotension and bradycardia, which is why you don't see them used a lot more. But they do have extra analgesic benefits, such as sedation. It's a great anxiolytic. Does have some pain relief, postoperative shivering. The nausea, vomiting is improved, agitation, and there is data that shows there's mitigation of the stress response to surgery on these medications. However, there's no real evidence that these are good for preventive analgesia. So you could choose to use it in the intra-op phase, or your anesthesiologist could, to try to overall provide some benefit in that period, but it doesn't really seem to have as much benefit when given as a preventive strategy, that is, starting before surgery and continuing it afterwards in the postoperative period. So with that, I would like to end and say thank you very much for this opportunity.